Hello, I'm Dr. Ross Hansen, Associate Editor for Seminars in Cardiothoracic and Vascular Anesthesia, and I want to welcome you guys back to our new video interview series. Today we have Dr. Sergey Karamnov with us to discuss his new article on sepsis after coronary artery bypass and open heart surgeries that's in our current online issue. After completing his medical degree at the Russian State Medical University in Moscow, Dr. Karamnov completed his residency in anesthesiology and then a fellowship in cardiothoracic anesthesiology training at Brigham and Women's Hospital in Boston. Following this, he was recruited to join the clinical faculty, where he currently serves as a clinical instructor at Harvard Medical School. In addition to his clinical work, Dr. Karamnov has published in a number of different areas, including three-dimensional echocardiography and inflammatory pathways. In our current issue, his article entitled Risk Factors and Outcomes Associated with Sepsis After Coronary Artery Bypass and Open Heart Valve Surgeries takes an insightful look at risk factors and outcomes following sepsis and cardiac surgery. We're fortunate to have the opportunity to speak with you today, so thank you, Dr. Karamnov.
Thank you very much for the invitation. It's a pleasure.
So jumping right in, kind of before we get into how you chose to research this issue, can you give our viewers a little bit of a sense of kind of the overall incidence of sepsis after cardiac surgery?
The overall incidence of sepsis after cardiac surgery varies and is reported to be anywhere from 1.2 to 5.8%. The significance of the issue, however, comes mostly from the fact that mortality of those patients who developed sepsis in the postoperative period can be as high as 80%. So definitely the issue is not to be underestimated.
So taking on such a big topic, for anybody who hasn't had a chance to go through the methods in detail, do you mind giving our viewers a quick overview of kind of how you got your data and how you chose to go about setting up this study?
This study is a multi-institutional retrospective cohort study. We used the National Surgical Quality Improvement Program and a SQIP database, which prospectively collects data including preoperative, intraoperative, and 30-day postoperative variables for patients undergoing various surgical procedures in approximately 500 institutions across the United States and Middle East. So we had data from 2007 to 2014 time period, and we identified almost 17,000 patients who underwent cardiac surgery during this time. 531 patients of them developed sepsis in the postoperative period, and we compared these two groups to identify risk factors for postoperative sepsis. As I mentioned, the incidence of sepsis is less than 6% in our study. In fact, it was around 3%. So to further investigate the impact of sepsis on postoperative outcomes, we use propensity score matching to identify patients among those without sepsis that are similar to the patients with sepsis on the wide range of characteristics like comorbidities, baseline labs, surgical procedures, and so forth. The idea of this procedure was to better isolate the causal effect of sepsis on postoperative outcomes.
So can you talk about some of the risk factors that you guys found?
We found that patients with advanced ASA class, like class 4 or 5, were more prone to develop sepsis. These patients are critically ill with likely compromised and dysregulated immune system. Interestingly enough, we also discovered that patients who are unable or only partially able to independently perform daily life activities before the surgery were at increased risk of developing post-cardiac surgery sepsis. This is of interest as this risk factor is potentially modifiable. And one can argue that prehabilitation is a measure that could be used to decrease sepsis risk in these patients. Prehabilitation techniques usually involve some combination of exercise, nutritional optimization, and psychological support. And it is well reported to be successful in improving postoperative outcomes for both cardiac and non-cardiac surgery. Certain patient comorbidities were associated with a higher incidence of postoperative sepsis as well, like renal insufficiency, morbid obesity, diabetes, congestive heart failure were the most prominent of them.
So I think with all the research that's going on in cardiac surgery and other specialties about frailty and these types of prehabilitation questions, this is really interesting stuff.
Thank
What
you.
kind of differences in outcomes did you find between the patients that did and didn't develop post-surgical sepsis?
Well, first, patients who developed postoperative sepsis were at a high risk for a number of additional complications, including need for reoperation, unplanned reintubation, prolonged mechanical ventilation, acute kidney injury, deep venous thrombosis, as well as such devastating complications as cardiac arrest and even death. Secondly, we also need to recognize the medical social aspect of this problem, as a hospital length of stay in the septic patient group was also almost double to those patients who did not develop sepsis. The mean hospital stay was 26 versus 12 days only between those two groups.
So how do these findings compare to those in the non-cardiac surgical populations?
We see certain similarities when it comes to risk factors associated with development of postoperative sepsis in cardiac surgery patients in our studies and priorly published studies on in general surgery population. Specifically, advanced age, high BMI, emergent nature of the surgery, as well as comorbidities like diabetes, renal insufficiency, were associated with higher incidence of postoperative sepsis in patients after general surgery. And we see the same results in our study as well. In prior studies, the risk of adverse outcomes, such as prolonged hospitalization, acute kidney injury, death, were also higher in general surgery patients who developed postoperative sepsis. And again, in our study, we see this results as well. At the same time, there are certain differences when it comes to cardiac surgery patient population. We see that cardiac surgery itself may present an additional risk factor. For example, one recent study showed no significant difference in mortality between patients with normal and decreased left ventricular ejection fraction who were diagnosed with sepsis. In our study, however, we defined congestive heart failure as a distinct risk factor for developing sepsis that leads to higher mortality. That suggests that cardiac surgery itself may represent a risk factor for sepsis in patients with congestive heart failure.
So taking all of this, what do you think the next steps are in using your findings to work towards eventually reducing the incidence of perioperative sepsis in this patient population, other than the kind of prehabilitation stuff you discussed earlier?
We aim to identify the potentially modifiable risk factors that could be intervened upon preoperatively to decrease risk of postoperative sepsis. We have introduced multiple hypotheses for future work in understanding whether patient characteristics such as nutritional status, glucose control, and functional status, as I mentioned, could be optimized. We found that a low albumin level could be associated with a higher incidence of sepsis, and that suggests that nutrition is an important parameter which should be evaluated beforehand. Glucose control has been widely reported across literature, and we see again that patients with diabetes have higher incidence of sepsis. In general, early recognition of sepsis after cardiac surgery is another area that seeks improvement. Screening tools such as quick sepsis-related organ failure assessment and the modified early warning score have been shown to predict mortality outside of intensive care unit using vital signs abnormalities and physical exam findings. Development of such risk calculators for postoperative, post-cardiac surgery sepsis to better predict and promptly recognize sepsis is a very promising area of further research, and we hope we will continue that as well.
Well, thank you very much for your time, Dr. Karamnov. I think this is all outstanding research and very interesting, and we'll be interested to see where this line of investigation goes. Thank you again.
Thank you very much. Thank you. I appreciate it.